Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center in Fort Myers, Florida. Here with the person who runs Caring Medical Florida, my esteemed colleague, Danielle Matias. So welcome, Danielle. Look forward to talking to you today.
Yeah.
Probably one of the most common things that you see is chronic low back pain.
Probably every day. Yeah.
Yeah, and then what normally causes that?
Usually what we find, especially by the time people come to us, is there's undiagnosed joint instability or ligament laxity that's really at the root cause of the patient's problem.
And I think a lot of people don't realize how many conditions that chronic ligament dysfunction, I mean that's kind of a good term, like ligament dysfunction.
Yeah.
If you have ligament dysfunction in the lower back, meaning the ligament can't control the motion of the bones in the lower back, like how many things it causes. And I think, like when we talk about the neck, in the office here, like associated with the neck is the jaw and the shoulder and da-da-da. But actually it's similar in the low back too. There's many joints that affect the lower back.
So this actually, like this diagram, I go over with back patients, hip patients, pelvic floor patients. This really applies to a lot. So, we call it the lumbo-pelvic complex, right? And so there's up here your lumbar spine, which most people think about when they think about low back pain is the lumbar spine or those vertebrae, but really then you also have the lumbosacral, so how the lumbar connects to the sacrum. And then that really all kind of blends into the sacroiliac joints on both sides. And then if we wrap around this bone, we have the hip and then the pubic symphysis right here. So it's all this network that play off of each other.
And then there's just ligaments everywhere. The most common ligaments in the lower back that we treat are the sacroiliac ligaments. But, there's the lumbar ligaments that you were talking about, the capsular ligaments, which the motion is the facet joints.
And iliolumbar ligaments, which sit right on top of those SI ligaments there too.
It's amazing how many people, when you talk to them, they'll say, where's the low back pain? They literally will go on the side and it fouls here. So the sacrotuberous ligament. And then the interesting thing is the sacrotuberous ligament and the hamstring, they basically connect at the same exact spot, on the ischial tuberosity. So I don't know, how many times does somebody need ischial tuberosity treatment?
Not very often. Funny that you say that.
Okay.
People that come in, unless they have a high hamstring tear, a lot of times will come in even bilateral ischial tuberosity pain, and it's so many times it's from the SI joint. Absolutely, yeah.
So they get physical therapy and da-da-da, and they work on it, da-da-da, but it really isn't a hamstring issue, or it's
totally,
really,
totally.
And then, of course, we have the hip ligaments, which really literally wrap around the whole hip joint.
I would even say, to kind of go with what you're saying, where people point in their low back, a lot of times I'll see people that come in and they'll say, I have hip pain, and that's where they point. It's actually not their hip at all, but they call it that, but it's actually they're pointing over their sacroiliac joint.
And then why don't you just explain, we're going to show a motion scan, but what do we look for in motion scanning?
Yeah, so with motion scanning, meaning that we're actually x-raying a patient when they, bend over or extend back, palm flexion extension x-rays, we're actually looking to see if these vertebrae, like these squares here, stay in line or stay in alignment as the patient is moving. So if this is flexion, they're bending over, can we draw a line that connects all the vertebrae together? Or if there's instability, does it look more like a stair step? So here is L5 and S1. And so what we're looking at is when the person bends over, do these segments stay stable or is there excess motion? And you can see L5 is here, and then here we go. L5 is here. There's a big stair step to S1 where right over there everything really falls in line. So this is a great way to diagnose if somebody has lumbosacral instability or a lumbar instability as well.
What if somebody said to you, they had MRIs, they had this, or they had that? Why didn't the MRI show the instability?
Well, most people have had all those, by the time they come here because they've gone through this whole
workup.
They've gone through this whole workup with all these different specialists. But most of the time, they don't get any images when they're moving, right? So you can get an MRI where you lay flat and it would still provide some good information probably, but not the same way that a motion scan would.
Well said. That's why you go through all the different conditions. This is the main point of this talk.
I see this all the time. This is so much of my practice. So ligamentous injuries in the low back, what can they cause, especially if they become chronic? pain in your tailbone, coccydynia, sciatica, pregnancy low back pain. A lot of us know a lot about that. Like pelvic floor dysfunction, hamstring tendinopathy, which we talked about, pudendal neuralgia. That's a big one. I see that a lot, especially if that sacrum is unstable, pressing on the pudendal nerve. Post-surgical back pain. You know, I had a fusion or I had a laminectomy or discectomy and my pain is back. Really, the list is long and long. People that feel like they can't, you know, brush their teeth and spit in the sink without throwing their back out. You know, all these kind of things are really all related to ligamentous instability.
I was just thinking too, you had 4 pregnancies.
3. Last one was a buy one, get one special.
Yeah. You had double. You had twins. Okay, so 3 pregencies. Did you get any low back pain with that?
Totally, it was awful. Yeah.
Okay, and then did it heal, or have you needed prolotherapy after your pregnancies or not?
Yeah, so I was lucky enough with my first 2 pregnancies, like terrible back pain, terrible pubic pain, that really kind of resolved as soon as the baby was born.
Okay.
But with the twins, it did not. I had a hard time. You treated my back actually 3 times after they were born, because I had a hard time like putting them in a car seat, like bending over or even like loading the dishwasher. It was awful, the back pain after they were born. And now
doing good now?
Yeah, no, now it's great.
Okay, good. Yeah, I forgot. And then, you know, I've had sciatica. I've had sciatica, so you've treated my low back, and it's doing very well, so thank you. Why don't you explain this? Because, you know, like you know, in books, it always shows like a ligament goes from here to here. But realistically, when you look at, did you do cadaver or no when you were in PA school?
Yeah.
Like, it's amazing, like, when you do a cadaver, like, it doesn't look like anything like the book.
No, it looks like this.
So why don't you explain, like...
So what we're looking at here basically is just kind of showing, you know, you saw on the previous graphic, like, maybe how individual ligaments look. It's really this whole mesh network where everything kind of overlaps and is connected. So why we bring this up is because a lot of times patients will ask us, well, why do you do so many shots with comprehensive prolotherapy? This is why, is because all of these ligaments, they're all connected in one way or another, essentially through fascia, you know, direct attachments and so forth.
Yeah, that was well said.
Thanks.
This is a little bit complicated, but just wanted to kind of show something where if you have ligament dysfunction, so you're saying like that there's ligament dysfunction in the back, like there's so many things, like people often have seen a chiropractor, they have different, you know, pelvic is tilted anterior and da-da-da. Once you have ligament injury, how does the body compensate so it minimizes injury in the future, right? Because if you have a ligament injury, the body's going to do something. So what does the body do to try to limit the forces? So like you're pregnant, you're starting to get back, like what does the body try to do so you can still function? You may have pain, but...
So the way that I explain this to patients is a lot of times what will happen is if you have a ligament injury and the joint becomes unstable, like a facet joint, let's say, in your low back, your body will swell the area first trying to stabilize it. Now, you're not going to see that. You're not going to like feel it or see it the same way you would, you know, if your wrist was swollen, right? But that's step 1. And then eventually you'll actually get like this ligament muscle reflex will kind of ignite. So you'll get a lot of back spasms or back pain or muscle tightness as your body is trying to hold, you know, your vertebrae together. Because let's face it, if it's unstable, the last thing your body wants is for that vertebrae to move and like hit your spinal cord, right? So like those muscles will activate trying to prevent that. Long term, you'll start to fuse it on its own, start to get bone spurs.
I just want to explain one thing too. You probably find this too. The person goes to like a really good physical therapist, like very talented, and then they'll explain that they felt worse. So one of the things that happens is physical therapists bias, if you will, just like your bias is everything's ligaments, or my bias. No, it's ligaments. The physical therapist bias is everything's muscles. So they try to relax the muscle. So explain why when they relax the muscle, it could make the instability worse or their symptoms worse. Because there's lots of people out there that
This happened to me. This is a true story. So I saw this massage therapist who is phenomenal, who I still see. Like this is not a her issue. And got this massage to my upper back, felt amazing. I'm like, I'm definitely going back because I feel so good. But what happened was I went back and I swear, like she did such a good job that she knocked out all muscular stability I had. Like I felt like I couldn't hold my head and back up, and I'm hypermobile to begin with. So I 100% understand what patients are saying when they say that. Like, you actually feel worse because the person did such a good job. It's,
Well, they destabilize you. It'd be like somebody gets a Botox injection, which weakens the muscle, but then their symptoms increase because that muscle tension
was protecting.
Right. So in the low back, that can absolutely happen.
Yeah.
So if you've had physical therapy or massage therapy, or even an adjustment and you're worse, it's probably you have underlying lumbar instability or SI instability. Or explain how ligament injury and excessive motion eventually leads to tissue breakdown. Because a lot of people have been told they have degenerative disc disease or degenerative joint disease. So what is that? What do those terms actually mean, and how does ligament injury eventually cause that?
Especially with if we keep with the low back with the lumbar spine, people will get an MRI report that says like, oh, I have degenerative discs. Do we inject into the disc? And you can, but we don't, because we know that ligament injury is what precedes that. So if we're going to really work on trying to get your back stable and get the pressure off the disc so they can try to heal as best they can, is we have to get those ligaments strong and get that joint stable so that it's not wearing down your disc all the time.
Here and then, we've talked about this. So when you get up in the morning, you don't realize this, but you're about a half an inch to 3/4 of an inch shorter than when you woke up this morning. So in other words, when you lay down at night, the discs get rehydrated. So the discs get regenerated during the night. So the key thing to get the discs regenerated is you got to reduce the force on the disc during the day.
Yeah.
So the way you do that is you got to get rid of the destructive joint motion that causes destructive or excessive pressures on the disc and the other low back structures. Because if you don't do that, the disc cells will die, and the disc cells, when they die, that's called disc degeneration. When there's degenerative joint disease and the structures of the joint are degenerated, it means that there's been cells or tissue that has died. Like when somebody's missing the cartilage, the cartilage cells have died. So the way to regenerate it is you got to get at the root cause of it, which is basically ligament dysfunction, ligament injury. And then
this actually summarizes it perfectly. So here's a lumbar spine. So these are the vertebrae, and then these blue are the discs here. Right here, where it's red, this is the capsular ligaments. Okay, so those are the facet joint stabilizers. So let's say somebody sprains their back, they injure these tissues. Well, if they don't heal well, what happens is you'll actually, a couple things. One is it'll start to spread to other joints as they get overworked. And then if these are loose, basically these bones are moving more than they should, and that's what wears down those discs, which then will spread to more discs to the point where you have multi-level disc degeneration and you're starting to wear them completely down.
Yeah, and then this just kind of summarizes it. This is a peripheral joint, so this is like the knee, but the same ligamentous joint.
Yeah, same principle.
Degenerative cascade or gangrenous cascade occurs in all the joints. So the underlying cause of chronic joint pain, low back pain, neck pain, it starts with ligament injury. So once in a while, you and I will get a low back MRI report. So this was one of the reports that I got where it said, on the report it said, as a disclaimer, so the radiologist isn't sued, it said, the prevalence of findings in patients without back pain.
Yeah.
So that was like amazing. Like a radiologist is sending us to make sure that the clinician knows that just these findings that I'm finding on this MRI, 92% of people without pain have disc degeneration. Yep. 64% have a bulge, 32% have a herniated disc. So 1/3 of people without pain have herniated discs. So you got to be careful when you say the herniated disc is the problem.
Yeah.
It can cause a problem, but. So tell us about prolotherapy. Like, how often do you do prolotherapy?
Every 4 to 6 weeks is pretty average for a back injury. That could change depending on, how severe the instability. Sometimes we'll see people every 3 weeks. But, we said earlier in this video, we want to be comprehensive, right? We saw the whole kind of network of ligament tissue. So we're not just going to do one injection into the back. We know historically that does not work. So we'll do injections into several levels of the capsular ligaments, into the SI joints, iliolumbar. And yeah, it does work, but it's very much a mutual patient-provider thing. This is not waving a magic wand, right? This is us working to heal these ligament injuries and then coaching the patient on the best way to take care of it when they're not in the office.
Yeah, so you might monitor or change their exercise program or...
Yeah, absolutely. Or their posture, the way they sit. You know, if someone is a truck driver and they're sitting all day long, you know, if you're sitting like this, you know...
Yeah, that's true.
Right? We got to make sure that we're addressing all of that as well.
That's true. So from 2004 from 1994 to 2005, Caring Medical ran a charity clinic, so I was the medical director in a very poor part of Illinois. So through the data we did that for 12 years. So we decided once the clinic ended, why don't we look at the results of the care?
Okay.
So there's lots of different scientific papers, including on the back. So 96% of patients with chronic low back pain got more than 50% relief. Now, at that charity clinic, we just used dextrose prolotherapy. So I always say that these results are literally the worst results you should get with prolotherapy, because in private practice, we do a lot of other things, or we have other proliferants, and we make other recommendations than just doing prolotherapy. So what are some of the other proliferants or...
Well, we can always use PRP, platelet-rich plasma, you know, getting cells from the patient's blood, or stem cells in more severe cases, you know, from bone marrow or adipose fat tissue. And then I do a lot of times make other recommendations. You know, some people do need physical therapy in conjunction with prolotherapy, or they do need advice and coaching on things like posture and exercises like we talked about in order for this to work the best way.
Yeah, that's well said. This is just the data from the 145 patients that we treated. So some of the significant findings are here is that who a prolotherapist see, who you see and I see are really severe cases. Like in other words, we see where people have been told surgery is the only option, or the doctors who saw them prior to us said that there's no other treatment option. So in over 50% of the people of the 145, you can see how many were there. And then people are always like, is it really going to get me good enough where I could work out again? Well, you can see from this, just with dextrose prolotherapy, first of all, 97% of the patients treated said that it made their life better. And then 78% of all back patients got to where they could work out for greater than 30 minutes. And interestingly, in the 26% of people who the doctor said that you need surgery, so this is like they came to the charity clinic, even though the doctor said you got to get a surgery, of those, 90% after the 4 prolotherapy visits could exercise greater than 30 minutes. So that just shows you that it isn't just that the pain goes away, it's like the body can handle the force.
You're functional.
And this just, well, why don't you explain this, like even people who had a pain level of a 10.
Yeah, so starting level of pain. So people that came to your charity clinic and that's how they rated their pain, 10 out of 10. So over 90% of those people noticed greater than 50% pain relief. That's huge.
Yeah, that is huge. So what would you tell somebody who has chronic low back pain, or they have another diagnosis like a hip problem or pelvic problem, and then they can't seem to resolve it? What would you recommend they do?
I mean, I do think that they're, like in those cases, at least consult a prolotherapist, at least get their opinion. If there are definitely cases where if somebody does need surgery, we tell them. Yeah. But in so many cases, we're able to help them without it, which is great.
Yeah, and I think too, it's good to see the problem. So if possible, like the way we do it is we do motion scanning, because I always feel like if you see the problem, first of all, if you see the problem, then that now is part of the person's chart. So they go see a physical therapist, they see anybody, they now have objective evidence that they have instability, and then once you know you have instability, you can do something about it. And prolotherapy is very effective at resolving chronic low back instability.